esteemed professors, dear colleagues, I wish you a fruitful Congress. I have a laryngitis for the last 2 days, so my voice is a bit low. Hopefully you can hear me. Trying to switch slides. Actually, pseudostimulants are drugs that child psychiatrist colleagues are using, but in dementia so far, it's something that we pass to neurologists due to work burden. So when we actually refer to neurologists, let me actually define dementia. It actually comes from mens, which means mind in Latin. Therefore, dementia is losing one's mind. Having mental disabilities, American Psychiatric Association is defining dementia as a disorder that is affecting daily life practices. So it is a multiple ability disorder increasing with age. After 65 years, it's doubled, unfortunately, more for women. There were around 47 million dementia cases in 2015, and it will be 135 million till 2050. And each year in the world, there is 7.7 million diagnoses made. Alzheimer is the most frequently run into in dementia range disorders. Why Alzheimer? Actually, it was Alois Alzheimer who defined between 1901 and 1906. So actually, psychiatrically, Alzheimer is also referred to in terms of increasing amnesia, loss of autonomy. Just like dementia, Alzheimer's prevalence increases with age, especially after 65 years of age. The histopathology of Alzheimer has to do with tau and certain factors, synaptic range. So these anomalies, imaging in the limbic system has around 100% diagnosis authenticity. So there's inflammation, neuron and synapse loss, cortical and neurotransmitter system losses characterize Alzheimer's. So acetylcholine hippocampus is at stake. There's primary deficit in the cholinergical system in the brain, especially in the areas of learning and remembering. And actually, choline acetyltransferase is being lost to around 90% in the brain. So risk factors are advanced age, of course, being a woman, genetics, low IQ, concussions, depression, many chronic diseases, illnesses, and certain metal toxicities. These are among the risk factors. So there is early, middle, and advanced stages of Alzheimer. In the early stage, at least one daily life practice is deteriorating. On the middle level, aside from amnesia, there is attention deficit, continuation of attention, and in advanced Alzheimer, there is spatial and temporal orientation loss, amnesia, and linguistic deterioration. So we run into behavioral disorders a lot. Actually, apathy is one of the most frequently encountered. Apathy in Greek means loss of emotions, apathia. So in the content of the opinions concerning purposes, objectives, there is loss of motivation, and it's a neurocognitive syndrome in this sense. In neuropsychiatric diseases, we run into apathy, but it's mostly thought of as a symptom. In DSM-5, it's actually a subtype of personal disorders. So medial, frontal, perimetricular core, inferior temporal, bilateral cingulate, orbital frontal cortex. Dysfunctions are some of the dysfunctions we can refer to. In apathy, there is emotional, cognitive, and motor dimensions. Emotionally, the patient has difficulty starting and continuing with a plan cognitively, and in motor sense, the psychomotor activities are at stake. Apathy can be run into many situations in all types of dementia, in various diseases after traumas, in certain infections, in old age women, and in institutions like prisons or in centers where there are refugees. So how to evaluate apathy? Actually, apathy evaluation scale, neuropsychiatry inventor Pons, and you can have different definitions of apathy in various platforms. Actually, I would like to talk about non-pharmacological methods first. This is an older study on the effect of music on apathy. So half-hour silence, 5-hour live, half-hour live music, half-hour tape music. So live music leads to amelioration in apathy. Maybe not a medical term, but in a study, there's nihavend type of music in Turkish music, and it turns out to have an effect on apathy. Again, there was a study in 2007, and the test points were evaluated. And these patients also had agitation. So in the emotional stimulation therapy, there was less apathy in time. And also there were studies concerning sports. 12 weeks of aerobics leading to lowering of apathy. And again, from a recent study, sports turn out to be not effective in Alzheimer's disease. Another study has to do with spare time activities, music. Both of them might be effective in Alzheimer type dementia. TMS was searched. High frequency TMS can ameliorate symptoms in Alzheimer's, but actually, in a study from Turkey recently, high frequency TMS might lead to deterioration in certain neuropsychiatric aspects. When we come to pharmacological treatments, Alzheimer type dementia patients have cholinergic, serotonergic, GABAergic, neurotransmitter system anomalies. So there's a link between all these. So it's mostly FDA-approved drugs, I would say, but there are not too many of them. But then there are certain neuroinhibitors, and NMDA receptor blocker is being used in Turkey. Acetylcholinesterase inhibitors might be beneficial, and use of it till the advanced stages are recommended for cognitive benefits as well as delaying with institutionalization and the amelioration of certain disorders. If we come to antidepressant, actually these are older studies, free studies. Actually, no effect on Alzheimer. Histopalam and 2 other drugs were compared. There were some recovery. Again, another study on mice. Experiential Alzheimer was formed and fluoxetine was tried. So there was no significant result concerning Alzheimer. Fluvoxamine, frontotemporal dementia more than Alzheimer's. No effect of these three antidepressants that the interpreter cannot hear. Low dose risperidone was found out to be effective in Alzheimer-related apathy. So there are those drugs, new approaches that are not FDA approved. It's mostly tau and beta amyloid plaques at stake. Beta-estrogen inhibitors were tried, so they were actually inhibiting plaque formation, but they were stopped in phase 3. So there was both the blockage of plaques as well as the amelioration of cognitive deterioration. And tau vaccination was tried on mice. Amelioration in behavior, but not approved. Stem cell therapy, again, plaque blockage and inhibition, but not approved. Sodium oligonucleotide, ameliorating cognitive functions in early and mid Alzheimer's, and approved in China. Actually, there was this argument about plaque formation, but ACE inhibitors, as you know, are hypertensives. Acetylcholine secretion is being inhibited. Therefore, ACE inhibitors are lowering Alzheimer's risk, and it is good for depression in Alzheimer's. So ACE inhibitors need to be passing the blood-brain barrier. Lisinopril is being mentioned in this framework. And let's come to modafinil, which is tried in Alzheimer. It has many effects on dopamine and increasing the amount of dopamine in synaptic range. There was this case. Now that we're talking about apathy, I wanted to put it in my presentation. 78-year-old male patient. Modafinil was tried. And in apathy measurement scores, there were amelioration. And there was a double-blind randomized control study where 200 milligrams per day found out to be beneficial. There were 24 studies between 2006 and 2013. 2 modafinil use and not effective. And in Alzheimer, bupropion is not superior to placebo. It's mostly on frontotemporal dementia. So it's one of the rare studies. Amphetamine, again in synaptic range, it is having an effect on dopamine secretion. So in the studies conducted, 20 milligram per day amphetamine can be used in Alzheimer therapy.
But this is an antiviral used in Parkinson. The effect mechanism is not known clearly, but it increases number of dopaminergic receptors, and it increases the dopamine secretion. And again, a study about amanthalin, they were mostly related to frontotemporal dementia. This was the only study related to Alzheimer. 30 dementia patients, 14 of them are Alzheimer's. 50 to 400 milligram amphetamine was used, and it's thought that this can be an alternative to Alzheimer type. Then let's come to methylphenidate. Methylphenidate is binding to dopamine and noradrenaline carrying prohibitors is inhibiting reuptake of this albumin, and it increases the dopamine level in synaptic interval. First studies from 1975. It wasn't Alzheimer. Phenylethylamine and depression was researched, and 20 milligram methylphenidate had been found to be beneficiary in comparison to a patient. There are psychosis development in two patients, and when it is shown that there is a psychosis development, then they are excluded, and it was shown to be effective in Alzheimer's disease treatments. Apathy evaluation scale had been evaluated in a 12-week of study with 23 participants. 10 milligram had been titrated. In 4th, 8th, and 12th week, there were evaluations in mental test points, and in apathic evaluation scales, there were improvements. And there were a 6-week of study for this, for 20 milligram phenylate. In 2017, there was a meta-analysis with 15 studies. It's told that methylphenidate adding therapy can be making sense in a prospective double-blind randomized placebo-controlled trial with 60 patients. For 12 weeks, 20 milligram phenylate was given, and it was shown that treatment had effects on apathy, cognition, depression, and decreasing the caregiver's load. In a 2021 study in 10 clinical centers, 9 America, 1 Canada, in placebo-controlled study, there were 307 Alzheimer's disease. 20 milligram per day methylphenidate had been used. It was shown to be clinically secure and effective. Effect started. There was an early onset of effect, and the effect was suggested to be continuing for at least 6 months, and it was told that they were effective on daily activities. Actually, I have read many publications related to methylphenidate's effect on Alzheimer's disease. Methylphenidate can be used. It can be an alternative. This study said that we should be careful about the psychosis development. For not speaking very long, I wanted to end with this chronological work.